APEC Online Journal Club and the 7th of Tehran University of Medical Sciences Journal Club, which is a joint program, and I'm honored to moderate this session as well on behalf of the Educational Committee of Asian Pacific Endodontic Confederation. What happened so far is we start our program with the honor of having the first author and the first person who started this somehow innovative communication, Professor Venkatesh Babu. And Professor Venkatesh Babu is a very famous name in our field because, as you know, he is also the associate editor of the evidence-based publication in International Journal of Endodontics. So I asked him also to help me for introducing the sessions as well. And also, we are very honored to have in our second APEC International Online Endodontic Journal Club, a very, very popular name in terms of vital pulp treatment in the world of endodontics, Professor Nessrin Taha. Nessrin Taha is very popular everywhere when you're speaking about pulp tissue and you want to keep the pulp tissue rather than remove it from the root canal system. Some names may come to your brain. Obviously, it starts by the name of Mahmoud Turabinejad, who developed mineral trioxide aggregate in 1995. And then it comes to some very, very unique names, and Nessrin is one of them. Thank you very much, Nessrin, for accepting to be with us. But as you know, the format of our program is a bit different from the usual lectures. We start with presentation of the sessions of your publication, asking one of our postgraduate students to do that, and then they are going to challenge you. So you are in a red chair. So they are going to ask you why you published this article, why you said this sentence there, and you should defend. So you are now in a very hot chair. Be ready for that. Obviously, I'm sure we are here to learn a lot from you. But to be honest with all of you, it is very difficult for me to introduce Nessrin properly, especially when I have another colleague who is the president and the chair of the educational committee, Professor Ibrahim Abu Tahun, with me from the same country. I'm in Jordan. And so I'm going to ask Ibrahim first to introduce Nessrin. And then after that, I'm going to ask Professor Venkatesh Babu to give us a very short talk about why we are looking at the evidence, and then ask Arvind Rezai to start speaking about the article, and then we go ahead and we discuss with each other. So Professor Abu Tahun, please. Arvind, can you please just don't share anything? Okay, good. We have Professor Talal Al-Nahlawi from Syria. Hello, Talal. Assalamu alaikum. And also we have Professor Barbara Kayahan, the president of APEC as well. And so I'm using also this opportunity to let you know about the next session that Talal is going actually to somehow be host of the meeting, next month's meeting. So we will send you all the information at the end of this session. Okay, Professor Ibrahim, please go ahead.
Thank you, Professor Mohammed. Before I welcome my dear friend and colleague Nessrin Taha, which is really, we feel proud of her, especially in the field of regeneration. First of all, as the chairman of the Educational Committee of APEC, I'm really glad to share this, let's say, Journal Club webinar produced in cooperation with Tehran University of Medical Sciences. The fact is that the Iranian school is a pioneer in this field, and it's my duty to declare my gratitude for all these great efforts by the Iranian school and especially by you, Professor Mohammed. And before we get started, please allow me all to welcome the president of the Asia Pacific Endodontic Confederation, Professor Mehmed Baibura Kayuhan, Kayahan. And Professor Mohammed, thank you for your support, and you are honoring our meeting today. I can't miss to welcome also, let's say, the engineer behind all these events, Professor Mohammed Nikufar. With his great efforts, we have already made some very good sessions and several different topics. Our invited speaker, Nessrin Taha, needs no introduction. As we said before, just you read her articles and you can understand. I was honored actually to invite me as external examiner for the master students of her department in the same topics, and she knows that this is my favorite topic. And I can say that from first hand, I can assure her hard work and hard dedication, real dedication to regeneration, especially in mature teeth with vital bulbs. Today's lecture, I know Mohammed, you will speak about her, although I am Jordanian better than me because I know you very well. It's very important before I close my introduction for me because actually Professor Nessrin Taha will provide us with pragmatic and science-based knowledge on the treatment of vital pulp exposures on mature permanent teeth, which is really important for us to understand and realize. We used to focus on files, irrigations, tapers, short-term healing, but the fact is that this root canal therapy is not instrumentation techniques only. This is not the real endodontics. This is just the icing on the cake. The fact is that increased volume of literature is indicating clearly the regeneration potential in all teeth and at all ages. So, without undermining the efficacy of traditional root canal therapies, of course, the cultivation of future potentials in this field is, in my opinion, a strategic priority. To position dentists at the forefront of this field. Who is better than Professor Nessrin Taha to cover it? You are most welcome to our platform here in the Asia Pacific Endodontic Federation and Tehran University of Medical Sciences, and we are all waiting to hear from you all the news. You are most welcome, Professor Nessrin.
Thank you, Professor Ibrahim.
Thank you very much, Professor Ibrahim, for very nice introduction. So I'm going now to ask Professor Venkatesh Babu, the co-editor of the, let's say, evidence part of the International Endodontic Journal, which is the heart of the journal these days. Also, he is in charge for giving all the information about how to write any article in the future in IEJ. So with his leadership now, Professor Dahmer and all of the authors and all of the editorial board working together to present the future guidelines for how to publish in International Endodontic Journal. He is one of the very, very important assets for the endodontic world as well. So I'm going to ask him to tell us some very important information about why we should look at the evidence. And the reason that we choose an article like the one that we have today is because evidence are very, very important. Wenki, please go ahead. Wenki, you need to, yes, turn on your microphone and go ahead. Yeah. Yes, you're on now, please. Oh, no, not again. Yes.
First of all, I would like to say good evening to everybody on this floor. I would like to thank Prof. Nikufar for inviting me for this very good event. And I would like to say big thanks to this APEC and Tehran University of Medical University for running this wonderful show constantly. So I know very well how difficult to run this show each and every month, collecting the Zoom link and catching this audience and everything. So the main important aim for this program is to the benefit of undergrad, postgraduate and undergraduate and all the clinicians. So coming to the question of Prof. Nikufer, why evidence-based is very important in today's era is, as we know, today if you take any journal, any online, lot of journal is getting published. It can be a clinical trial, animal-based, laboratory-based studies and everything. So a lot of controversies coming in. For example, wonderful example is today's topic. How do we manage the tooth for Carious Pulp Exposure? What material we use to place? There are a lot of controversies here, even though in lack of clinical trial. In evidence-based, in review papers, we used to collect all this evidence and we assess the quality of this paper, and finally we used to give the conclusion saying that which is best, so that will be the take-home message for the clinicians to do it in their day-to-day clinical practice. So that is the main advantage of being your clinical evidence. That's the importance of evidence-based dentistry or evidence-based endodontics. So that's why please have a close look on this particular program. So it will be helpful for you guys, for especially for your clinical management. Thank you.
Thank you very much indeed. So Nessrin, now the stage is yours, and after your introduction, we are going to ask Dr. Arvin Rezai to start his presentation. Please, Nessrin.
Assalamu alaikum and hello everyone. Thank you, Professor Nikufer and Professor Ibrahim and President of the APEC for organizing such an exciting activity actually of Journal Club. It's as you said, it's very important to appraise the evidence available because of the effect on decision making and lots of publications, lots of journals, and many of the articles you read, you find there are certain defects that you cannot overlook, and it affects some decisions by clinician. So it's really important to have such high-level organizations of seminars to share thoughts, ideas, and available evidence. And it's actually a basic thing in any postgraduate program to run a journal club to discuss current evidence to guide this new generation of endodontists and share the knowledge from experienced endodontists. And actually, I'm looking forward to the presentation by Arvin and to starting the discussion. Thank you for your introduction.
Thank you very much indeed. So I'm sure Arvin now is ready to do that. So Arvin, if you want to share your PowerPoint, please go ahead and do that. While Arvin is doing that, I'm going to tell you the importance of critical appraisal. And as you know, we called it Appraise to raise because we believe that there are a lot of publication in all the journals that we need to look at them in the way of criticism and also appraisal. I'm not speaking about any particular publication, but in some of the publication, and you know, there are a lot of tools that we use them, and with the use of the tools that we can appraise, we can understand better about how to write, how to understand, and how to apply the evidence for our clinical work, as Wenki said. Okay, Arvin, the stage is yours. Please go ahead.
Hello. Hello, everybody. My name is Arvin Rezai, postgraduate student of Tehran University of Medical Science. Let me start sharing. I may apologize, everybody, because my laptop has got crashed and I had to share the slides with my phone, and maybe you may not have my picture. In the name of God, today we are going to...
We can see your presentation, Arvin, now. Please go ahead.
What?
We can see your presentation, so that's fine.
Yes,
Please
yes,
go
yes,
ahead.
Yes, okay. Today we are going to discuss with each other about conservative management of mature permanent teeth with Carious Pulp Exposure. Before starting the presentation, I may thank from Dr. Fatemeh Hamidzadeh for making slides and Dr. Nekufar for helping me to understand better this article. In introduction, we have to pay attention to high global prevalence of dental caries that we know all of us, but a prerequisite for preservation the pulp the structure is that we know that where is the healthy pulp and we preserve that and make that healthy because we need this healthy pulp tissue. As we know, inflammation when progresses through the pulp, it makes some degenerations for the pulps, and when the severity of the inflammation increases as the progression toward the pulp, it makes the degeneration more severe and cause more problem for us in our tooth. Even when we have Carious exposure, we know that the inflammation has not get this all of the pulp thoroughly, and maybe most of the time when we remove about 2 millimeters of the pulp, all of our problem will be solved and we could preserve the rest. And the experiments have shown that it's not uncommon. When we remove the pulp, we see remain pulp healthy in pulp chambers and other pulp horns. And so it makes us hopeful that we could preserve the rest of the pulp and make it healthy. Historically, this procedure was not supported a lot. It was discouraged by many clinicians around the world, and they mostly prefer to extirpate all of the pulp as a procedure that we call pulpectomy, and they prefer to do that. But yeah, the point that it started here was that we saw that when we have a pulpitis, not all of the pulp was thoroughly degenerated, and so we get to come to see where the pulp is remained and to preserve that. Here it's mentioned correctly in the article that we have to regard the pulp irreversible just when the degeneration and the progression of the carious lesion is up to that point that it's not possible for us to remove all of the carious lesion, all of the degenerated pulps, and we cannot make this progression stop and or maybe go back and make it better. The reason, in my opinion, one of the reasons that this procedure was not supported historically was because of bad memories by using calcium hydroxide, because as all of us know, calcium hydroxide have some drawbacks. For example, poor microbial control, poor seal that makes micro leakages. So because of these drawbacks, it had bad results in the procedure, so they didn't, the clinicians hadn't a good memory from this procedure because of choosing a bad material for that. And another reason for not supporting this procedure in the teeth was that it was a belief historically that blood supplies in mature teeth was insufficient to promote healing for us. As the time goes
May I ask you to stop, please? May I ask you to stop?
Okay.
If you go back to your previous slide, please. Because the good thing is in our next online journal club, we are going to discuss about the another very good publication by Dr. Sheldon Best, that we have him with us today as well. Thank you very much, Sheldon, to join us. And we are going to discuss about the use of calcium hydroxide, because the next session is about the outcome assessment of teeth with necrotic pulp and apical periodontitis treated with long-term calcium hydroxide. And now in this sentence that you extracted from the article by Nessrin, we said bad memories of clinical outcomes of direct pulp capping with calcium hydroxide. So we can see that calcium hydroxide sometimes is showing us a very good outcome when we use it maybe inside the root canal. I'm sure Dr. Best is going to discuss that in our next session very well. When it comes to the vital pulp treatment, we said bad memories of clinical outcomes. Nessrin, can you help us with explaining what do you mean out of this sentence? The third sentence in the PowerPoint, bad memories of clinical outcomes of direct pulp capping. What do you mean out of it?
Yes, Professor Nakufar. I think bad memories, it's just an expression from Ravin. I don't recall writing that in my article, but he's just rephrasing what I've written about calcium hydroxide. It would have been nice if he had quoted some references actually in his slides. And with this particular point, he could have quoted the study by Barthel et al. When direct pulp capping with calcium hydroxide at 5 years had 37% only success. And with further follow-up at 10 years, it was even lower. The main problem with calcium hydroxide is that it's hydrophobic. So it's not actually easy to apply it over the pulp. It does not stick easily. And at histological level, there are studies that compare the dentine bridge that has been formed or initiated by the placement of calcium hydroxide compared to MTA. And it was found that there are lots of tunnel defects in this bridge. So it's not a complete barrier. So in case of any coronal leakage from the coronal restoration, there might be channels for reinfection of the pulp space and failure of the treatment. One more thing, actually, many of the studies that have used calcium hydroxide in direct pulp capping, they do not differentiate the clinical diagnosis between reversible or irreversible. When there is irreversible symptoms of pulp injury, just clinical signs and symptoms, you would expect that infection has proceeded down inside the pulp tissue. So simply removing the caries and placing calcium hydroxide would not be enough to heal the inflammation and get rid of the infection. That's why there will be a slow process of degeneration. Even if it appears successful at earlier years, by time, this infection will progress and cause pulp death. In the cases of clinical symptoms of reversible pulpitis, direct pulp capping, if performed with calcium hydroxide in specialist hands, it may work because you need to place something that will ensure insulation above it, like a resin-modified glass ionomer, for example, and good coronal seal. And we have some studies on calcium hydroxide that have shown high success rates, but not all studies, as you said. We have to look into the details of each study separately before we condemn calcium hydroxide. However, there are few randomized clinical trials in the literature, one of them by Lee et al., one of them by Kodzinia et al., that compared the use of calcium hydroxide to MTA in direct pulp capping. And they found a huge difference in the success rate. And it's actually recommended by the ESE position statement that calcium hydroxide are superseded by the calcium silicate materials to maximize the success.
Thank you, Nessrin. Sheldon, what do you think about that? I'm very keen to know what do you think about that, because I know you are one of the you are in favor of calcium hydroxide somehow, although inside the root canal system. Please go ahead and tell us, what do you think about that?
Well, the cases that we treated were all necrotic with apical lesions. We weren't looking at keeping the pulp alive. And I think the outcomes that we saw were largely because the calcium hydroxide was placed and a reservoir of calcium hydroxide placed over the top. All of the teeth were banded. There was no potential for fracture or reinfection. So I think it's a different study altogether, of course. I have not had any difficulties with calcium hydroxide in those circumstances, and I think our outcomes were in the 90% range.
Okay, thank you very much. So I think the most important thing is to know that when we apply calcium hydroxide in terms of vital pulp therapy or direct pulp capping and compare it, and it's not possible to compare it when we use it in somehow when we have an apical lesion and we put that inside the root canal as intracanal medicament. So I think we can somehow agree on that calcium hydroxide in terms of its way of application can be very, very useful, and still it is one of the very best material available in endodontics. And when we compare that with the way that we want to use in direct pulp capping or vital pulp treatment, it comes to the issues that Nessrin properly addressed them. Thank you very much. Arvin, please carry on.
Okay. Yes, the phrase "bad memories" was mine, not Professor Nessrin Taha's. Okay. As I was going to say, as we go through and significant improvements has occurred, we saw that the situation inside mature teeth is not as bad as previously supposed. We found lots of growth factors. The several of them was mentioned in the article, and we saw, and by finding them, we find out that maybe it may have greater regenerative potential than what was thought previously. After calcium hydroxide, several materials was found that they were bioactive materials. The advantages of them was they induced release of growth factors that had to work for us, modulate inflammatory process, and induce repair inside the mature teeth. And one very important advantage of these materials that was that they had good marginal sealing, and they provide good marginal sealing for us, that after preserving healthy pulp tissue, it's very important for us to not have micro leakage inside that area. Besides all of these, we found the role of fibroblasts that have lots of work to do inside the healthy pulp tissue. For example, they modulate the repair or dentinogenesis inside the healthy part, and also it has anti-inflammatory potentials by recruiting the complement system of the body. It's interesting that fibroblasts can directly kill bacteria inside the pulp, and also as you see in these two in this slide, it has two complement that mentioned. One is C5A, one is C3B. C5A is a chemotactic agent that attract the neutrophils, the phagocytes inside the area, and C3B is a complement that directly binds to the bacteria and makes it easier for the phagocytes to kill the bacteria. So the aim of this article is to review the palpable status beneath Carious exposure and to discuss about clinical management of mature teeth with Carious pulp exposure, and discuss about these three important elements of this. One is case selection, one is material, and the other one is the clinical procedures that makes for us outcome. Okay, first of all, we are going to talk about the palpable status beneath the Carious exposure. As the carious lesion progress, the tooth became less permeable by creating a situation that is called tubular sclerosis by deposition of mineral components inside the tubules, dentin tubules, that makes the speed of the progression less. And but as the carious lesion progresses, odontoblasts under the carious lesion, most of them are dead. And but the good news is that odontoblast-like cells has the ability to replace these lost odontoblasts for us and to substitute them and perform their work. The criteria. Okay.
Excuse me, Arvin, may I comment on the previous slide, please?
Yes, sure. You go. Yes, you're welcome.
Please, Nessrin, please go ahead.
Can you please go back to the previous slide?
Okay.
Yeah, I just want to highlight one point of odontoblast-like cells, because this term is actually under debate. There are recent publications by Ricucci et al. Who looked at the histology of the cells that are responsible for repair or production of mineralized matrix under deep carious lesions. And he actually found that we cannot call these cells odontoblast-like cells. I know that I have used this term actually in my review, but I didn't want to dig deep into this topic, but I have been receiving inquiries about it, so I thought I might highlight it. I actually like to follow the findings of Ricucci et al., who found that it's actually fibroblast-like cells. It does not resemble odontoblast. There is no regeneration of odontoblast by any of the calcium silicate materials. But I wonder, is this really important if it was odontoblast-like cells or fibroblast-like cells? What matters actually is the function that this cell will perform, which is the antibacterial action, deactivation of antigens, bacterial antigens, and laying down calcified tissue. If we have a cell that will do this function, we don't actually care if it's actually true regeneration of the odontoblast or not. And there might be one good point, because mature teeth were usually criticized because of low vascularity and low cellularity. But there are plenty of fibroblasts in adult teeth, because there are lots of fibers and fibroblasts. And if fibroblasts perform such wonderful function of stimulating C3A and C5A, we can claim a high healing potential for a mature tooth, actually. So maybe I need to apologize here for using the odontoblast-like cells term in my paper. It was not a very scientific one, and I will try to avoid it next time in my upcoming publications. Thank you.
Thank
Arvin.
you. Thank you very much. Very good. Very good. Thank you. Arvin?
Thanks a lot.
Now sorry, before we go, we carry on. There is a question from Fatima. Fatima, please go ahead. Turn on your microphone, please. Yes,
right.
We can hear you.
Hi there, all of my really great professors. It's nice to see you all together on this very special day for me. Since Nessrin mentioned about Ricucci, actually 2 years ago, he joined the vital pulp treatment meeting in Amsterdam, and he was very calcium hydroxide lichen professor, and they had a kind of a little quarrel with Camilleri, Professor Camilleri, about MTA versus calcium hydroxide. Actually, I would very like to see Dr. Nessrin debating the same things with that respected professor here. He also mentioned that if there is a caries in one side of the dentine, and if we get a histological sample from that, actually this might not reflect the whole situation in the whole dentine. And he said that if there's a caries exposure, then we cannot use the term we cleaned the exposure site, because he mentioned that histologically it's caries all the way, even if he cannot detect it in that specific sample. What would Professor Nessrin think about that?
Do you mean the thank you, Fatima. Nice to see you and happy birthday.
Thank you very much.
So nice to see you in very good health. Actually,
oh my goodness. Oh my. Oh
Okay, Nessrin, happy birthday, Fatima.
Oh, thank you, Dr. Nekufar. Thank you very much for this lovely presentation. I'm very touched. Thank you. Thank you very much.
Okay, Nessrin, please.
Yes, Fatima, I have a very high respect to Professor Ricucci, and I consider him as a mentor for me in my vital pulp therapy stuff. And I know that he still believes in calcium hydroxide, but I assure you that thing that works in his skillful hands doesn't work in the hands of anyone else. Besides, he always uses a pure calcium hydroxide powder. So when he places it, it's in a powder format. So you can't say it's hydrophobic. It's not like when you use a paste format. And he works under ideal conditions. He gets a very high success rate with long-term follow-ups of his own cases. And I can understand that. And you can see this in the Turkish studies by Çalışkan. I don't know how you spell the name. I'm sure
Çalışkan.
Çalışkan in 1993, 1995. You see a very high success rate for calcium hydroxide in skillful hands, but because those two scientists are very accurate in their inclusion criteria, they don't mix up cases of different diagnoses, different symptoms when they write articles. And considering your notes on the histology of Carious Pulp Exposure, I always share Professor Ricucci slides in my presentation, and I always quote his 2014 studies on correlation between symptoms and the actual histological and histopathological status of the pulp. And I totally agree with him, and I see his beautiful slides, and he confirmed the finding by very old studies by Seltzer in the 1960s, that when there is a Carious pulp exposure, you see infection and bacterial penetration within 2 millimeters of the Carious front. Whereas if you look at the contralateral side, histologically, you can see very normal architecture. Ricucci also demonstrates in several cases of histology that there are, even with the same cases of reversible pulpitis, you don't see replicas of the same histological pattern. One case will have like extension within 2 millimeters. Another case will have a very limited bacterial infiltration. And actually, we don't need to remove the entire inflamed tissue. What we need is to remove the infected tissue with bacteria, because inflammation drives the repair process. So, and even the diagnosis of normal pulp, any normal pulp in the histology, it was shown to harbor some areas of chronic inflammation by previous restorative procedures or cracks. So his findings of histology actually form the baseline for adoption of vital pulp therapy procedures, and accounts for the high success that we are achieving actually in our trials.
Okay, thank you very much. Arvin, please.
Okay, thanks a lot. Now we are going to discuss about maybe the main point that's mentioned here in this article, and the main topic that has been discussed here. The critical point when the pulp transit from reversible to irreversible, because it's very important for us to find this point, this cutoff, to preserve our tooth. So maybe we can say it's impossible nowadays with our nowadays tools to determine correctly which tooth is reversible and which tooth is not reversible by thermal and electrical stimulation. That is our nowadays tools for examining the tooth. So by having that, we go through the classification of pulpitis. These two terms, reversible and irreversible, has from long time been used as a part of our diagnostic scheme to diagnose the tooth and find our treatment plan. However, these terms the validity of these terms had been questioned by Professor Dahmer and his co-workers, because he found that there is poor correlation between clinical symptoms and actual histologic status of pulp, and this is important because it's directly correlated with healing potential of pulpal tissue. So it's been concluded that there is no clear cutoff point between what is actually reversible and with what is not reversible by the tools that we now have and the symptoms that the patients shows for us. But we can say outcome of our works depends on these two components: the nature of the procedure that we perform. Maybe we do direct pulp cap, partial pulpotomy, full pulpotomy, and beside that, the material that we use in these procedures, they together form the outcome for us. About material, as I mentioned before, calcium hydroxide, calcium hydroxide was not a very good material because of these two drawbacks that lead to poor outcome in the historical studies. But after introducing calcium silicate-based cements, for calcium silicate-based materials such as MTA, biodentin, and other materials, they showed better outcomes and they led to resolution of pulpal inflammation and preserving the pulp's vitality for us. So finally, there is a judgment from the authors of this article that it's better about this classification, that it's better to for us to just use pulpitis for our diagnosis, not further designation, irreversible or reversible. It was a judgment that I think the authors has made from their findings.
Arvin, may I comment on this?
Okay.
Yes,
sure. Please, because there's also a question about that as well, that they said, Professor Kumars asked that question and said the terms initial, mild, moderate, and severe pulpitis can be used to replace current terminology for reversible and irreversible pulpitis, better reflecting condition encountered in the clinical setting. And I want to add another question and say that cariously exposed pulp, it doesn't give us any more information about the inflammatory stage of the pulp tissue. So we need a clue, especially where we want to transfer our idea to our student or to our colleagues. We need a very clear definition of the pulp status. So, and you raise a very, very, I would say, revolutionary issue in your article by saying that the classification of pulp tissue is not going to give us a lot of information. Please go ahead and give us your explanation.
Yes, Arvin, please, if you go back to the previous slide. I'm sorry for keeping asking about this. The reason why I've written this was actually to answer the first question, because there was a publication in IEJ that introduced the endolite concept, and that we have to be minimally invasive and preserve the pulp. And they started with this classification: initial pulpitis, mild, moderate, severe, based on the duration of lingering pain in terms of seconds or minutes. And I find that very confusing to the clinician. And you cannot actually differentiate between what's mild, what's moderate, because the sensation of pain is very subjective. And as a clinician, we know that many patients differ in the way they report pain. What is painful to me, maybe it's not painful to you, maybe it's very painful to another person. And knowing that it's initial or mild or moderate will not help anything, actually. We just need to know that there is inflammation, so there is pulpitis, and the presence of a positive response to cold test just will exclude pulp necrosis. Because cold test is very sensitive. In its absence, it indicates necrosis, but it does not give any indication how far inflammation has proceeded. And this has been proven by Damar, a study in 1980s. Many of asymptomatic teeth were found to be necrotic. Many of necrotic cases were asymptomatic, and there is a great variation in the histology of symptomatic teeth. Some of them will have chronic partial pulpitis, some will have severe pulpitis, and so on. So actually, we will know if pulpitis reversible or reversible only after we perform our procedure. If it's successful, we will know that we have been successful in our diagnosis. But at this stage, there is no sensitive test to show the actual status of the pulp. And we may only find an indication while we are working. If you expose the pulp, you have to see a fresh red exposure site. There should be some bleeding from that site, and we should be able to arrest it by, like anyone, by a simple pressure, for example, 2 to 4 minutes or to 6 minutes. The amount of bleeding from an exposure site has been suggested as an indicator, possible indicator of inflammation, but there is actually no evidence in the literature on this. The only study was by Matsu et al., where he related the amount of bleeding to the degree of inflammation. But I have been reading that study more than 10 times, one time over one time, and I find contradictory recommendations based on his findings. He says it would be more successful if you don't get bleeding from a pulp exposure site. For me, I would worry. Maybe the pulp is necrotic. Why there is no normal bleeding there? And he divides the time into like 20 seconds, more than 20 seconds, less than 2 minutes. It's actually a very limited time. You can't really judge. If I have a carious exposure, it has to be bright red. If it doesn't bleed, as a clinician, I will poke it in my sterile endoprop to see if it's bleeding normally. If it doesn't bleed, I will take more of the pulp tissue to reach a probably healthier architecture as I see under magnification. And by this, I progress from decision of pulp capping to partial pulpotomy to full pulpotomy. This is the only clear current guideline for the vital pulp therapy procedure. But following ESE recommendation, I will never attempt direct pulp capping in teeth with symptoms of irreversible pulpitis. So I do not agree with the diagnosis scheme of initial, mild, moderate, and severe pulpitis.
Okay, thank you. And there's a question from our president, Professor Barbara Kayhan. Barbara, please go ahead, turn on your microphone and ask your question. Professor Kayhan, please go ahead. You need to just turn on your microphone, please.
Could you hear me now? Could you hear me now? Yeah. I'd like to thank you all for joining and sharing your knowledge. It's really our pleasure. I'd like to thank Professor Nekoha once again for this outstanding organization. And I'd like to thank Professor Taha for being with us. And my question was about severe pain at nights and patients who take also painkillers. Don't you think that this is the step of irreversible pulpitis? And if this is a step of irreversible pulpitis, and don't you think that the pulp has still the repair capacity? And another question is about bleeding. Sometimes, you know, we use anesthetics with vasoconstrictors, and sometimes it affects the bleed in the pulp. So we cannot decide what to do in these cases. What do you think about these issues?
Yes, thank you for your questions. Considering the symptoms, we all still follow the e-diagnostic terminology because that's the best of what we have until now. If there are symptoms of pain disturbing the sleep, spontaneous pain, lingering pain, we will make a clinical diagnosis suggestive of a reversible pulpitis. But if we look at the histology of these teeth, as reported by Ricucci et al. 2014, you find that 84% of these painful cases have some areas of infection, while 16% were diagnosed normal. And furthermore, in these 84%, the infection was limited, as we said previously, to a certain extent from within the pulp. Yeah. So that if you do partial pulpotomy or full pulpotomy...
Excuse me, even with severe pain at nights and patients take painkillers, even in these cases, but the clinical approach, do you change the clinical approach? For example, pulpotomy, do you prefer pulpotomy in these cases rather than direct pulp capping?
In these cases, direct pulp capping, as we said, is not recommended because there is infection already inside the tissue. So we have two choices left, either partial pulpotomy or full pulpotomy. When I first started our trials, we started with full pulpotomy because it's less technically challenging. And the second thing, that almost 100% you removed the entire coronal portion. So you have manage the majority of cases where there is extension within 2 or 3 or 4 millimeters. And we get very high success rates. And even in cases with severe pain and reversible pulpitis. So I got a thought, why can't we try partial pulpotomy and save more of the pulp? Because especially in these cases, it's very easy during follow-up because you can see evidence of positive response to call test with partial pulpotomy. So you make sure that your procedure is successful. So we tried this in my study on partial pulpotomy in JOE in 2017, and we found 85% success rates. It's successful, but it's less than full pulpotomy. With full pulpotomy, we got 93% over 3 years. With partial pulpotomy, we got 85%. I can find the reason that probably we have missed some infected tissue because when you do partial pulpotomy, you can't be 100% that you removed the entirely inflamed tissue compared to pulpotomy. Now,
excuse me, maybe in partial pulpotomy, one of the reasons is the application of restorative materials. It's easier to apply materials with during full pulpotomy, I think. In partial pulpotomy, the stability of MTA, for example, or the application of MTA can be a little bit problematic. What do you think about this issue?
For me, I don't think so. I would say with calcium hydroxide, it will be problematic, but with MTA, with calcium silicate materials, because with partial pulpotomy, you already drill 2 to 3 millimeters, so you have a cavity. So it's easy to place it. So it was not a challenge in this term using calcium silicate materials. We used MTA in our study. So, but Now I follow actually the procedure of first, in all my cases of irreversible pulpitis, I attempt partial pulpotomy. If I can achieve hemostasis within 6 minutes, which is like 3 application of 2 minutes pressure, I will do partial pulpotomy. If the pulp is still oozing and I can't achieve hemostasis, I proceed to full pulpotomy. Full pulpotomy doesn't work, I extirpate the pulp because I can't be any more resistant. So I like to progress from partial pulpotomy to full pulpotomy.
The second question by Professor Babera was about the local anesthetic and the use of them and the effect of them on the bleeding. And Arvind, please unshare the slides while we are just chatting and discussing. Okay, carry on, please.
Yes, with the vasoconstrictor, I mean, you can't perform your vital pulp therapy without local anesthetic. If you do not place a vasoconstrictor, the efficacy will be reduced, or the duration of your anesthetic will be reduced as well. And I can assure you, even with anesthetic, with a vasoconstrictor, patients undergoing vital pulp therapy, maybe you have noticed yourself, they will still feel pain. But the procedure is really quick. When you cut 2 millimeters of full pulpotomy, it doesn't take like 1 minute with a high-speed drill, and then the patient will feel an immediate relief. So, and we always encounter bleeding, unless in necrotic cases. So I have not noticed that it affects the evaluation of the amount of the bleeding. And I may add one more thing, that there is a study by Teixeira in 2001. He actually did pulpotomy and he used intrapulpal anesthesia. I don't usually attempt.
They inject directly inside to control the bleeding.
Directly, yeah, there is one study in 2001 and they have got very high success rates. Personally, I would not attempt this because I don't want to affect the healing potential. When you want healing, you want the vascularity. I don't want to do vasoconstriction at the very critical stage of pulp healing. I hope that I have answered this.
Yeah, okay, thank you very much. Thank you very much, Professor Babera-Kayhan, for all of the support that we have received from the APEC and from you personally. Thank you very much. So we carry on. And now I'm going to ask Professor Fazliab to turn on her microphone, and because she has got another question. Mahta is one of the pioneer in doing a lot of vital pulp treatment in Iran. However, she doesn't belong to Tehran University of Medical Sciences, and somehow she is one of the competitor, but I'm going to give her permission to talk. Okay, Mahta, please go ahead.
Thank you. Hi to everyone. I'm so glad to meet you, however it's online, but it is very sweet for me. Thank you, Professor Nekoufar, Dr. Nessrin Taha. I'm very proud to meet you online. I have to challenge one of your statements. Please guide me if I'm wrong or right. You stated that if we have inflammation, it is possible to keep the inflamed pulp in situ and just continue the treatment and do the capping process. As you can remember, CVEC just classified the pulp tissue beneath caries as just going downward. It is the microabscess, then inflammation, and after that, the most deep layer is the normal pulp. And one of the criteria of successful direct pulp capping, or what each of the vital pulp therapy treatments, is doing the treatment over the healthy pulp. As we always say that we have to escort the inflammation with the bleeding being an indicator of this inflammation. And you just said that we can keep the inflamed tissue, and I have a question on that. How do you just support this statement? I have a problem with this one, if you can guide me, and that's all. Thank you.
Thank you, Mahta. Nessrin, please. Nessrin, your microphone is off. Please turn it on.
Thank you for the question. Actually, I wanted to differentiate between inflammation and infection. You can't leave infection. That's why I said you can't cap a tooth with symptoms of irreversible pulpitis, because histology showed that there is infection inside the pulp. With inflammation, we need inflammation to drive the repair process. So you have to remove the infected pulp, and you may leave some of the inflamed pulp. And histology showed that infection or bacterial invasion is limited within 2 to 3 millimeters from the carious front. And if you like, I can share one of the histology from Dr. Ricucci to show evidence on this. I think we both agree there is no conflict between you and me. We need to remove infection as reported by Schvick, but it's not necessarily to remove the entirely inflamed pulp, because there is a healing potential for this inflamed part.
Okay, thank you very much, Nessrin. I have a question myself, which is a bit more practical rather than evidence-based. While we have a very extensive caries, we are worried about the restoration as well. So sometimes we need to do pulpectomy and root canal treatment to insert a post or to prepare the coronal part for the sake of restoration. And in that case, I think vital pulp treatment, even though the pulp is inflamed or even the pulp is healthy, is not the case. What do you think about that and how we can answer to this question? Because many dentists ask me same question.
You are right, Professor Nekufar. We are not attempting heroic endodontics. First, endodontists are called specialists in saving teeth, and second, specialists in saving pulps. If you can't save the tooth by a subsequent restoration, why do we want to save the pulp? So one of the main inclusion criteria that the tooth should be restorable by a coronal restoration without the need for retention from the pulp chamber or the root canal space. Otherwise, vital pulp therapy is contraindicated. It's like when you get a traumatic injury for an upper central incisor and the crown is completely gone and there's a vital pulp shining. You can't cap it because you will need a post space. You have to remove it, unfortunately. So yes, you are right.
Oh, that's great. Thank you very much, because this is always the issue. And Fatima Betul is going to ask the next question. But before that, I have my second question, and it is about the calcific metamorphosis. Speaking about the calcific metamorphosis, is it a disease or it is a part of the healthy tooth? Because one of our nightmares as endodontists is to deal with the fully obliterated calcified tooth or calcified root canal. And I hate to see that calcification is initiated and I cannot do anything about that. So what do you think? Because one of the consequences or one of the bad consequences of vital pulp treatment, whatever it is, direct pulp capping, partial pulpotomy, or even pulpotomy, and according to the evidence, almost 30% of them end up with calcific metamorphosis, which is a nightmare for endodontists. And I can see many of my colleagues as endodontists, they are happy about my question and they are against of the vital pulp treatment because of this, the very bad outcome and consequence of that. What do you think? And what is your answer? So I'm challenging you.
Yes, no, I'm happy with your question. First, my comment that calcific metamorphosis it's an entity after traumatic injury. So it's a pulp canal obliteration after traumatic injury where odontoblasts lose the proper neural control and start laying down dentine at a higher rate than it should be. And it has been reported only in traumatic studies with pulp canal obliteration. Incidence of pulp necrosis in teeth with PCO is less than 3%. So it's not actually an indication to initiate root canal treatment if you see evidence of calcification. And that's evident by several studies by Andresen, the father of traumatology. If you want to go to vital pulp therapy, there are no study, all the studies on vital pulp therapy, none of them reported actual percentages of amount of calcification or complete canal obliteration. I'm quite confident from this because I have just finished writing a chapter on vital pulp therapy and its side effects, and I've reviewed all this literature. There are some reports of 1 or 2 or 3 cases of what we call narrowing of the root canal space. And this thing happens in young patients more than in adults. I've noticed narrowing of canal space, but it's still discernible on the radiograph. And if you need, for whatever reason, to perform root canal therapy, you will still be able to access the canal, you might find some obliteration just near the orifice as part of dentine bridge formation, but then you will access the canal and perform it. And I'm very optimistic that we will rarely need to do vital pulp therapy after RCT after vital pulp therapy unless there is break in the coronal seal. May I ask you a question? Do you do regeneration procedure or revascularization? Yes. Do you worry about calcification and bone inside the root canal after regeneration?
Oh, yes. I know what you want to say, but yes, I'm not worried about that. But if I'm worried about the restoration in the future, yes, then when I see the calcification is going to block the root canal, I may initiate my root canal treatment.
Yes, so that's why I take it a chance to encourage a good coronal seal and maybe crowning of the tooth immediately after partial or full pulpotomy, especially with this publication in JOE by Tan et al. In 2020 on long-term pulpal and restorative outcomes of vital pulp therapy. And they found that late failures are mainly due to leakage, not to inflammation of the dental pulp. So I'm very optimistic around the outcome of vital pulp therapy. And let me tell you something, I had to myself to do retreatment from some vital pulp therapy referred from the pediatric dentistry department. And I tell you that we could locate canals with the microscope, with your loops. And when you are an endodontist, I don't think you will find it difficult. Maybe a GP will need to refer it, but I don't think it's a challenge for an endodontist.
Okay, thank you very much. Fatima Batul, go ahead. And then we have Hadi Asadian after that. And after Hadi, I'm going to ask Talal also to give us his idea, because we know that Talal can do root canal treatment even without looking at the canal and find the orifice easier than us. But definitely I'm going to ask him to tell me when he see the calcification, what is his reaction to that as well? Fatima Batul.
Okay, I have two questions to Dr. Nessrin. Two of them are
Please make it quicker because there are a lot of questions.
Both of them are clinical related. The first of them is they are both about hemostasis. The first of them is the agent for hemostatic, the solution that we use, because Çalışkan uses saline and Rikuchi uses sodium hypochlorite. And there are different ideas about the material for hemostasis. And the second one is about the time, because Dr. Nessrin said that 6 minutes is necessary, but some of the texts say that 5 minutes, and if not, then 5 minutes more. And some of them says something differently. So I'm wondering your ideas, because I do a lot of vital pulp treatments in my clinic. So I'm wondering about these. Thank you.
Okay,
thanks, Fatima. First question, considering the hemostatic agent, several studies used saline, sodium hypochlorite, chlorhexidine, and there is only one study in the literature that looked at the effect of a hemostatic agent, and it's in pediatric dentistry. You find it as reference 43 in my review, which is the subject of this. They compared sodium hypochlorite versus saline, and they found that the outcome was higher when you use sodium hypochlorite, which might be understandable because of the antibacterial activities or even the necrotizing effect, superficial effect of sodium hypochlorite that may induce repair. So I personally am more comfortable of using an antibacterial agent, which is sodium hypochlorite, which is most widely used in the studies. Regarding the time of hemostasis, there is no general agreement on that. Some studies reported extension of the time up to 20 minutes. But as a clinician, I will give up well before that. I will not attempt hemostasis over 20 minutes, actually. I try it 2 minutes. If it doesn't work, another 2 minutes, another 2 minutes. In one of my studies, we did 5 attempts up to 10 minutes. But after that, just for the sake of a study, I tried 3 times. If it works, works. If it doesn't, it doesn't. That's why I say 6 minutes. So 2, 2, 2. So 3 attempts of 2 minutes. Shorter than that, you will not achieve hemostasis.
Okay, Hadi Asadian, please. while Hadi is trying to turn on his microphone, I'm telling you, Nessrin, I have received a lot of questions about the calcification. So we need to discuss that more because somebody are worried about the pulp stones. Some of them are worried about the calcific metamorphosis that obliterate the canal. Okay, Hadi is ready now.
Hi again. Thanks very much for your nice and informative lecture and your good comments. I would like to ask you a question about the bleeding because you focused more on the bleeding and hemorrhage from the pulp, and you did not mention the pulp itself. I think that there is a difference between bleeding initiating from the pulp and the pulp residues that you can find from the exposure. Because I have met a large number of cases with pulpal necrosis, even bleeding from the inflamed tissue from the periapical region or the granulomatous tissue from the periapical region that leads up to even the coronal space of the pulp. So if you focus on the bleeding itself, I think it is deficient and may be misleading to have a correct diagnosis between the severely inflamed or even degenerating pulp and pulp which is near to normal or even mildly inflamed. So there is a big difference. And another question of mine is that we focus on more histological points of view, but at final, we are drawing our attention to the clinical point of view, and there is a correlation between the clinical and the histological criteria. And I think there is a big discrepancy, and if there is a very big difference, I would like you to explain more of that.
Nessrin, I couldn't hear Hadi very well. If you understand the details of the question, please give us an abstract of the question.
Yeah, the first part, I didn't see any question, although his voice was not clear, but I didn't get any question in his first talk. In the second part, he's saying that we are concentrating on histology and then we are talking about clinical procedures. And then I want to highlight something, Hadi, that the statement that there is poor correlation between symptoms and histology is not correct, actually. There is good correlation as proven by Rikuchi 2014. But this when we say there is good correlation, that does not mean that the pulp tissue is entirely infected, as we have just discussed several times so far during the last hour. So there is good correlation, but that correlated area is confined to a certain part. So if we do partial or full pulpotomy, we will be dealing with it. With bleeding, I can summarize for the first part, if I did understand right, I can summarize it to you. If you cannot achieve hemostasis, then you can't place your calcium silicate material. And subsequently, it's contraindication for vital pulp therapy. If you have any other concerns, you might.
Okay, Nessrin, I think Hadi is trying also to say that. I think Hadi is trying to say that if there is no bleeding, and the bleeding comes from the preapical area to the coronal part, well, this is necrosis. This is somehow we will say that the bleeding from the apical part is a sign of the infection rather than the sign of the vitality. On the other hand, we need bleeding because when we have bleeding, that means the pulp tissue is vital. Can you somehow explain that as well?
Of course, we need some bleeding. If you have a cut in your hand, don't you expect the cut to bleed if it's normal? And the normal clotting time is between I may explain something, it might be helpful to Hadi. Sometimes, as we said, when we have the pulp exposure and you are thinking about direct pulp capping, you look under magnification. If you see grayish areas, yellowish areas, if you see dentine debris inside that pulp exposure, you should know that there is something going underneath. There is some sort of inflammation. That's why you have to explore. You can't pulp cap immediately unless it's uniformly pinkish, reddish, no exudate, no any suspicious appearance of a healthy pinkish pulp.
Okay, Nessrin, thank you very much. I'm going actually to emphasize on the importance of calcification, because I have received a lot of questions about that endodontists are still worried about the calcification. And we all know that one of the very, very good hand endodontists is Talal Al-Nahlawi, and Talal showing us a lot of video that he find the canals, he deal with a lot of difficulties and challenging endodontics. So I think asking this question from Talal can also help. Talal, what do you think about the calcific metamorphosis outcome? Are you worried about that, or you may say that it is easier to do pulpotomy first, and then if something happened, then we are able to deal with the calcification? What do you think about that?
Actually, thank you very much for this very nice activity. Special thanks for Dr. Nessrin. I really adore her academic work, my friends, all Professor Tahoun, Brahim, and also Professor Mehmet. Thank you very much for this nice activity. Actually, I do believe that even though I'm doing a lot of root canal treatments, but I do attempt always to try to do vital bulb therapy. And I believe, and please correct me, Nessrin, if I'm wrong, in cases if we have obliteration after pulpotomy, maybe we have something related to, still we have some infection inside the pulp, but we didn't realize that there's still infection. Maybe we didn't really estimate that we have a controlled bleeding, or maybe we have some areas of yellowish that we didn't even pay attention to. So in case of such circumstances, maybe we're gonna have some obliteration, although the percentage is low, as Professor Nessrin mentioned, but it could happen. I don't know, and also I want your intake on the type of the material. It will influence if we go for calcium hydroxide and calcium silicate cements. Is there any difference in terms of obliteration? This is a question for you also, Professor Nessrin, but for a clinician point of view, if we have a case of obliteration inside the root canal, I think it is, as the calcification will start coronally, then it will go toward the root canal. It's very important for us to have a magnification and to appreciate the colors of the secondary dentine or the tertiary dentine that formed after the application of calcium silicate material. And then by troughing them, by using the ultrasonics, I do believe that we can reach the area of the canal, which sometimes will be very narrow. But I will tell you something. Why most of the dentists are afraid of such scenario? Because even though if they have microscope or they have loops, for example, and they can reach the very narrow canal at the beginning, they will ledge the canal. This is the problem. They will create a ledge, and once they create a ledge with a narrow canal, it's almost a nightmare. It is almost very difficult to open the original bath in order to control the infection inside. I do believe the fear of calcification is like that. But if we follow the pulpotomy, for example, rules, and we are very strict, and we apply the calcium silicate material, I myself do believe I have cases more than 7-8 years of recall and with great success. And I do believe that the pulpotomy for cases with irreversible pulpitis, when we have all the circumstances for application of calcium silicate material, is a high successful procedure. But also, again, we have to go back to earth. We have to go back to reality. We have to appreciate that not all dentists, they have microscopes. Not all dentists, they can understand how to differentiate between the colors. And if the bleeding is coming from this area or from down beneath, and I feel that the superficial area, which is necrotic, is bleeding, what is the type of burr they are drilling? For example, they are removing the caries with the burr, they have to change the burr. When they are cutting the bulb, they have to work with aseptic circumstances, restrict aseptic circumstances. So because of this very, very complications, most of the dentists, when they try to do a vital bulb therapy, they will end up with failure. and this is will cause the bad reputation for such application. But when you go academic, you can see with the hand of Professor Nessrin, with hand of Professor Riguchi, a very high success rate because they follow all the circumstances. We still are waiting for a statement that will tell us when to go for such treatment protocol. But regarding the calcification, I told you, it is not so difficult. You have to appreciate the colors and then very important to know how to deal with the canal after getting the catch of it.
Thank you.
Salah,
Thank you.
I might take it easy. If you are a GP and you don't know, you are not confident in differentiating color or with magnification, you can just simply do pulpotomy. You don't need to differentiate between partial or full pulpotomy. Yes. And it's less challenging for the GPs. Considering calcification, I cannot comment more actually because there is no evidence in the literature on percentage of calcification after pulpotomy. I may ask you all or all the attendants in your Facebook group, have you ever been faced with a post of a case that received vital pulp therapy and with the pulp canal obliteration? And if you look at the figures that the two figures that I've selected in my review, you can see 5 years follow-up of partial pulpotomy in a 50-year-old patient, and you can trace the canal entirely. I did not choose this one because it's a beautiful one. I've chosen it because it's 50-year-old man, and it's clearly showing the outline of the canal, and it's representative of other samples. And I have to tell you that with my studies, I was not the operator. My postgraduate students were the operators, and they were just calibrated during 6 months or 1 year before the start of the thesis. So you just need to practice it 1 or 2 or 5 times, calibrate yourself, and it will be just straightforward. If you are afraid of a car accident going to the street and hit by a car, you cannot stay for your entire life at home. So I will not, it's the same thing apply. I will not prohibit myself from doing pulpotomy fearing of pulp canal obliteration.
Thank you. Mahta, please.
May I add something? I don't know why we have tendency to ignore the role of the material used for pulp capping here in induction of pulp canal obliteration. As we know, many successive events have to take place, many of which directly depend on the type of material used. For example, we have to, the cell recruitment has to happen. After that, the initiation of cell differentiation. After that, upregulation of many secretory events by the odontoblast-like cells. And after that, the last but not least is the downregulation of secretory activity. Many of the materials like calcium hydroxide do not do the last part, especially the last part. I mean, they do not downregulate the secretory action. As a matter of fact, calcification goes on and on and on. And that's a problem that we have here. Some of us think that calcification is a problem. Some of us we think that it is not a problem, actually, especially if you are endodontists. But I have to add that if you perform this treatment with the material that does not carry the risk of pulp canal calcification, we can have very more predictive results by vital pulp therapy, as because we are not hoping to see the calcification anymore. That's all. Professor Nessrin, how do you think of that? Or especially Dr. Nekufar, I want to know your comments. Or Dr. Fatima.
This is against my comment. So so you are in favor of Nessrin to saying that. But Nessrin, I think the most important part that I was expecting to receive that from Arvin, which you mentioned in the other part of your article, is about the material that Mahta raised the issue. So I think it's good time for you also to tell us, what do you think about, is there any difference between material? Because people now, I can see they send their comments, my colleagues, my very good colleagues from around the world, they say that what about MTA comparing to biodentin, comparing to other material? Is it important to use or mention any name? Obviously, I have not received any money from any of them. So I am completely independent from the companies, but obviously it may have some effect as well. If I develop a material, I try to show that this is a very good material, this is amazing. What do you think? I'm sure you also not receive any money from any of these companies, and I deny any conflict of interest myself. So please deny your conflict of interest and tell us what do you think about the material.
As you said, I also deny any conflict of interest. Mahta, I did not get if there was any question in her discussion, but we cannot blame one of the basic requirements for a pulp capping material or a vital pulp therapy material, that it should be biocompatible, induce cell differentiation and hard tissue formation. So now we cannot come back and blame these materials for obliterating the pulp, because that's the main objective. We have used these materials for providing a good seal. And when it stimulates this, it stimulates a dentine bridge. It's not necessarily to happen inside the root canal. This is the first time that I hear from Mahta that there is no down regulation by calcium hydroxide. But I would say that all tricalcium silicate material, they release calcium hydroxide anyway. So there wouldn't be a difference in these materials in terms of this aspect. Considering different calcium silicate materials in vital pulp therapy, there are few studies that actually compared MTA with biodentine, MTA with the Iranian calcium and rest mixture, and they found a similar response because mostly they have similar biological behavior. Considering mature teeth, there will be, inshallah, during this year, a randomized clinical trial coming up from my school on MTA versus biodentine versus total fill, which is a bioceramic material over 1 year follow-up in symptomatic teeth, mature teeth, obviously, and there was no significant difference in the outcome between the three materials. The only one concern is with MTA was discoloration, as you know, and we found it not very common actually in pulpotomy. It may be common in revascularization, but in pulpotomy it was not of a big issue. There will be also, inshallah, a study coming on that, on discoloration induced by calcium silicate materials in pulpotomy compared to MTA. Now, it's a matter of handling properties. I feel very good in my hands during pulpotomy. It's not like you are doing a retrograde filling that you say the handling properties of MTA are objectionable. Biodentine is easily mixed with a capsule. Total fill comes pre-mixed. So it's actually the operator convenience, what he likes to use, what he is comfortable with. But I believe all the three materials have similar biological properties and probably as it will appear, inshallah, similar good outcome above 90%. So I have no certain preference for material.
Yeah, so if I conclude that, you're telling us that the material itself is not very important. Obviously, you are speaking about comparing different calcium silicate materials or high calcium silicate based materials, comparing to, for example, dical or light cure calcium hydroxide. Am I right?
No, I put all tricalcium silicate materials in one category versus calcium hydroxide versus any resin containing material. I would be very concerned. I know that you've published one study using TheraCal, which is a resin modified calcium silicate material, and you had a high success rate, which is contradicting histological studies that shows TheraCal induce pulp inflammation. We need more evidence in this regard, considering resin containing materials, but the most literature shows that it's irritating to the pulp because of the resin. So I wouldn't be excited about any material containing resin. I will stick to the category of hydraulic calcium silicate based cement, MTA, total fill, CEM, biodentine, new MTA plus, ortho MTA from Korea, all these brand names, you are familiar with it.
Okay, thank you very much indeed. One of the very important policy that we have to start our session punctual and to end up that after 90 minutes. So now we have 2 minutes, and let me tell Arvin my apology that Arvin couldn't finish this beautiful article, but we had a lot of beautiful discussion. I learned a lot. And thanks from all of you, almost 150 participants that we have today. I'm very happy to receive that. Okay, so this is again a happy birthday. Thank you very much, guys. We already did that. Thank you very much. Oh my God. Okay, today we have the birthday of Fatima Batu. My colleagues, actually, they are very excited about her. She is one of very good colleagues of our school, and she traveled to Tehran and gave us this opportunity to teach to our students. And I hope one day Nessrin can do that for us as well. So not Nessrin, I use this opportunity to invite you as well. And while we are going to finish this session, I'm going to share the poster of our next session, which we have this honor to have Dr. Sheldon Best with us. Next month, we will discuss about the outcome assessment of teeth with necrotic pulps and apical periodontitis treated with long-term calcium hydroxide. Dr. Sheldon Best from Canada, please go ahead and give us 1 minute advertisement and tell us why we should join to your journal club, which is going to be presented by one of the students of Professor Talal Al-Nahlawi, Dr. Ahmed Abdullah. Okay, Dr. Sheldon, please.
As a graduate of the University of Toronto under Shimon Friedman, we have particular interest in endodontic outcomes. As a full-time clinician, I'm concerned about my patients and their treatment long-term. I think that we have identified a way to treat necrotic cases predictably and have healing of lesions in a simple fashion.
Okay, so
and I hope to see you all there.
Yes, we see all of you with us, hopefully. And thank you very much, everybody, for joining us. So I'm going to ask Nessrin to give us the last talk and say goodbye to everybody. Nessrin, please. And thank you very much again.
I actually, thanks to you all. I always enjoy talking endo and vital pulp therapy. And it's a very productive session. To me, it's my pleasure to invite you also to my presentation in the upcoming AAE meeting, the fall meeting. I will be sharing a session as an invited speaker with Professor David Witherspoon. So if you are interested in vital pulp therapy, we can have a little bit more and we share our experience. And I'm looking forward for the upcoming journal club next month with Dr. Sheldon. It's a very interesting topic for me as well. And I would like to thank you all for your interaction.
Okay,
and,
so I'm going to ask everybody to turn on their microphone, and if they are happy, turn on their videos, because we want to put our hand for Nessrin and Arvin for their very nice presentation. Thank you very much, and goodbye to all of you.
Thank you. Thank you, Professor Abu Tahoun.
Ibrahim, your microphone is off. Please turn it on.
Thank you, Mohammed Nikufar. Thank you, Dr. Nessrin. We really enjoyed it. I wish I could make a final comment on all this discussion, but we'll say
go ahead. Please go ahead.
Between us.
No, yeah, please go ahead.
Yes, because the fact I do believe that science and research do not lie. To all those who are claiming that it doesn't work, I don't know what happens. If we fail in pulpotomy, I have heard this from Dr. Turabinejad, it's because we fail to do pulpotomy, or we fail to do the pulp cap. We fail, as when we fail in conventional root canal treatment. I know there are many questions still unanswered. We need to answer them. We are lacking standardized protocol for these procedures. Yes, we agree on this. We still have a diagnostic dilemma. We need, because of course we have a problem. We use tests that we have been using for 200 years. As Dr. Turabinejad, I wish we could have Dr. Turabinejad with us. Anyhow, but the fact is that we cannot go back now. We should move toward more ethical treatment plans or treatment shapes, schemes, I don't know what we call them, but we cannot do it forever. This is what I want to say. Thank you very much, Dr. Nessrin. I enjoyed your lecture, and thank you, Dr. Turbenjad. You are the giant. Thank you very much for all your efforts. Thank you for all. Thank you.
Yeah, I think this is a very good idea to mention the name of Mahmoud Turbenjad with us, because without his amazing production, mineral trioxide aggregate, we couldn't discuss about the vital pulp treatment. And I remember that the first days that he developed his material, there was a lot of enemies against his idea of vital pulp treatment. And he changed our attitude about what we want to do these days. And this is a paradigm shift that now we can easily discuss about the vital pulp therapy without worrying about the consequences. Thanks to him as well. Thank you very much. Barbara, last word, please. Mr. President.
Our president.
Thank you very much for coming and joining us. It was an outstanding lecture. I'd like to thank Professor Taha again, and to all our colleagues and to all our friends. And we are looking forward to next session next month. Professor Sheldon will be with us. And I'd like to thank you all again. During these hard days, it's real science. And thank you very much, Professor Nekofar, for this exceptional organization. Thank you very much. Thank you for all.
Okay, goodbye, everybody, and see you next month. Goodbye. Thank you very much.
Thank you all.